Hello, everyone. Welcome to RheumNow's coverage of EULAR 2024. This is day three, and this is the day three recap where the faculty gets together and has a bottle of wine. I hope we have a bottle of wine somewhere. And we discuss what we saw today at the meeting that we thought was new and important. I'm Jack Cush, normally in Dallas, Texas, and I'm joined by Bella. Dr. Bella Mehta from New York City, and Dr. Anthony Chan from the UK. All right, so we're just going to go around the horn, give you our favorite abstracts from today. Why don't we begin with Dr. Chan?
Thanks. I want to start off by the poster tour, which I attended this morning. They're really nice things to attend first thing in the morning with some coffee. And there are two posters that they were almost side by side, but almost saying slightly different results. That's is poster 0266 and poster 0278. And this is looking at the question of cycle or swap. Once patients fail the first TNF inhibitor, do you go to another TNF? That's the cycle strategy, or do you swap? And these were the questions asked. The first one, 0266, is from the Italian group. There were 347 patients, 217 in the continuous group, which is the cycling group, and 130 in the swapping group. And basically, the end of it, they found that there was a slight difference in advantage with the switching group or the swapper group compared to the continuous group. And I asked them the questions: was it because of inefficacy or was it because of side effects that made them switch? And they said they haven't done an analysis yet. So I think again something to be considered when they look at the data. 5 years, there was slight advantage of the swapping group compared to the continuous group. Almost adjacent to that, at 278, was the Dutch group, who also presented the same Kaplan-Meier survival curve. This was also PSA patients, 406 this time, 307 in the continuous group and 99 in the cycling group. And here, this time, they did look at whether it was inefficacy or whether it was side effects that made them switch. And essentially, the bottom line is that they found no difference whether the switch was due to inefficacy or due to side effects. Both groups did just as well, whether they continuous or whether they were the swapping group. But they only found a slight difference in male patients. Male patients did less well if they were swapped compared to female patients, but no difference overall in terms of the DAS28 CRP. So I thought it was interesting because it probably influences in some way some of our own practice, and we may often keep people in the same group cycle if they had what we call secondary failure, and they've responded for a long time but then stopped responding after a period of time. And in those who didn't respond from the outset, sometimes we tend to swap.
So, what were the drugs that were involved here? And usually in these studies,
Yeah.
what we're talking about is cycling amongst the TNF inhibitors, using one of the five,
Yeah.
and switching to another mechanism, to
IL-17.
another.
It's IL-17. Yeah.
So this
So
is TNF switching or cycling
yeah.
versus swapping to another MOA, correct?
Yes, correct. And that's IL-17I, IL-17 inhibitor.
For
For the
treating what
swapping.
condition?
PSA, psoriatic arthritis.
Okay, this
These
is
both
PSA.
studies are psoriatic arthritis.
Oh, okay, I got you.
Yeah.
So
Yeah.
this is basically a TNF versus IL-17 switch, and the data on this for at least RA, there was a lot of it, and it always favored switching to another MOA,
Mm.
meaning that the story is that if you use a first biologic like a TNF inhibitor in RA, you get a 60-40-20 ACR 20-40, 20-50-70 response. But if you keep staying within TNFs, it goes down. It goes from 60-40-20 to 50-30-15, et cetera. And this is one of the rationales behind the swap to MOAs, because you then get a second time around, you get a 60-40-20 with a new molecule, a new MOA. And up until recently, there wasn't a lot of research on doing this practice or these choices in psoriatic arthritis. So it's interesting to see that they're kind of following the observances of what's seen in RA. Based
Mhm.
on this data, does this change how you'll treat PSA patients when they don't ultimately don't respond to their first TNF inhibitor?
I think the first group were, as you say, favoring the what we know, which is to switch mode of action, where they found that the people who swapped did better. But I think the second group, probably what they were saying is that people who had responded to TNF for long periods of time and then, say, in a couple of years failed, you probably could cycle in those patients. That I think is the kind of takeaway I've got from these two posters.
I guess, I mean, it was observational too, right? So, I mean,
Yeah,
I don't know if they showed us how many people were lost to follow up. Like, you don't know what happened to those
yeah, we don't
follow-up
we don't have that detail. They just gave us the 5 year kind of survival curve,
survival curve. Like
and
5 years is a long time for all these patients to be followed and not lost.
I think
Um,
it wasn't designed as a study. It was more an observational, and they were doing it because of prescribing practices. So the second study, they had a drug sort of a protocol that they had to follow. So in the first 5 years, they were following the continuous strategy, and then they had a change in their policy, and then they went to a switch strategy. So this has allowed them then to do the two comparisons.
I guess, are you guys doing like anti-TNF antibodies? I mean, that's the rationale then, if you like take it for a long time, and then there's antibodies to it.
So therapeutic drug monitoring to make decisions, not very much in vogue. I'm not doing it. I don't find the point of it. Only recently have there been studies suggesting its utility in RA and PSA, but I can't say there's a lot of data to support it. The reason why this is an important this kind of data, even being observational, is important is that the longitudinal retention studies on our advanced therapies in psoriasis and psoriatic arthritis is abysmal, meaning that survival on those drugs is not very good. That at 3 years, less than 50% are still taking the original, and sometimes like only 30% are taking the original biologic, whether it's an IL-17 or a TNF or a 12/23. And so knowing what your next best choice might be to get the best success really is going to help. So we probably need more studies like this. It would be better if they were a little better designed. But when the best you have is observational data, that is still the best you have. So interesting.
Mm.
Bella, what did you like from today?
Um, I like this again. One of the studies from the poster tour. It was poster number 0277. So this is canakinumab prophylaxis in patients with gout who are getting methotrexate and pegloticase. So instead of, the concept is that if you are in a gout flare, you give corticosteroids and then initiate methotrexate and pegloticase. We know canakinumab is now approved for gout, for recurrent gout, where patients cannot be treated with NSAIDs, corticosteroids, or colchicine. This is rather an expensive proof of concept study, study, but they did this in 12 patients who had gout flares, gave canakinumab, and methotrexate, initiated methotrexate, and in 2 or 3 weeks after gave pegloticase, and then saw, if they had any gout flares going forward. Again, 2 or 3 patients of these 12 um, had sort of dropped out, had problems with serum uric acid rise, and thus pegloticase needed to be switched off. So basically, data from like the mirror RCT, but showed that it does work and it does work well. And those patients where you absolutely can't do steroids, this might be a good option to initiate for gout flares, along with sort of more prophylaxis treatment with pegloticase and
So
methotrexate.
how many patients ultimately benefited from this since there were dropouts? You started out
Uh,
with 12. How many people did well in this?
I think, out of the 12, three dropped out, eight of them did well.
Okay. So again, it's expensive double biologic therapy. obviously highly complex patients.
Highly
But
complex patients, like it's one dose, 150 milligram. Um,
and what's the timing here? So patients going on pegloticase should be on an immunosuppressant like methotrexate, mycophenolate. I like azathioprine, and then you start the pegloticase, and so that they don't get the anti-peg response that would limit its use. And when do you start the canakinumab, and how often do you
like
give it?
they just tried to do it like once, like during the flare. So they didn't, I mean, at least in this study, they just did it once. How often? I mean, I hope not, right? Like, hopefully the gout flare subsides and you don't need to keep giving it.
But my experience with pegloticase is that when you give the pegloticase, they flare after every time. And my patients needed to be on. I used way too much steroids because let's say they were on like some low dose, 5 milligrams a day, and then they get their pegloticase infusion, and I have to bump it up to 20 for 5 to 6 days and then hope to get them down. And I was giving the pegloticase every 2 weeks because these are people that had big time
Yeah,
tophi
yeah,
and total body urate. So they were constantly in this surge of flare and non-flare that I must say wasn't always well controlled by steroids. And maybe canakinumab would be a great option, albeit an expensive one.
mm, mm.
I don't.
yeah, yeah.
And can you give it repeat? Did they have people where they gave it repeatedly?
Not in this study, but like we've given canakinumab repeatedly with biologics in stills, like combined if we needed to. So I guess we can.
Yeah. If you can get it approved, and certainly is a new indication for the management of flares. This is pretty novel. I'd be really interested in seeing how this goes forward and whether how it could be protocolized. Because once you get a protocol, then you can better study it. You can maybe get it better funded, and patients can benefit from it. I can tell you my two patients where I had to use recurrent steroids were really bothered by the flares and the recurrent high doses of steroids. And I don't know if they were more bothered by the pegloticase, which was benefiting them, but they
Hmm.
were basically tied to it, like someone with cancer has to go and be tied to chemotherapy, and they don't like doing that on a regular basis. So, while in the beginning they may be enthusiastic about what you're doing, when you're 6 months in and you're still doing infusions of pegloticase, they're not wild about it, and they still got a long way to go. And I must say it's these are really difficult cases to manage. So this kind of
Sure.
option could be really advantageous for
I mean,
some.
we've been doing anakinra, right, in gout for like these sort of um, get us out of a tough situation where you don't want to use steroids a lot. I feel like when I've given pegloticase, it's maybe initially they've gotten flares, but then it stabilizes and then flares stop happening. And the tophi also significant. I mean, we know that with all the clinical trials and the data, I mean, it goes away. It
Yeah,
does.
and
So
that was my impression going in. But the ones that patients I got, they were, I guess they had so much total body urate that it
Mm.
was just going to be just an ongoing thing. So maybe I had the wrong. But in this, when you're using pegloticase, these are always tough cases to manage, right? They're never going to be simple gout, and gout is already kind of challenging in its own way. But anyway, I like this as another option. So, my abstract from today was a poster, POS 1035. It's a study. It's one of many studies at this meeting on interstitial lung disease, which is getting a lot of play. I mean, I
Mm.
think some of the themes that I'm seeing at this meeting is there's a big theme on lupus that we talked about last night, and steroid use that's playing out. There's a lot of action on direct to I was going to say direct to consumer advertising. Instead, I meant difficult to treat RA. There's still some good reports on preclinical or clinically suspect arthralgia, but ILD is another one that's getting a lot of play. And this one I thought was important because it's a cohort study of 172 patients with rheumatoid arthritis associated interstitial lung disease. And in this cohort, that bad things happen to these patients, right? They get more infections. They certainly have more deaths. And in this study, there were 44 ILD related deaths, and 7 patients went on to require transplant. And what they did was they looked at this cohort was selected because they all had 6 or more serial assessments of PFTs and FVC measurements. And they then plotted out the FVC trajectories for these patients over time. And they showed that about 35% of patients had a stable or improving FVC trajectory, but 14% had a rapid decline in FVC in the 3 years or more of follow-up, and over 50% had a slow decline. It turns out that it didn't matter whether you were a slow decline or a rapid decline, that the outcomes were kind of the same as to the bad stuff. The bad stuff being the need for lung transplant. If you had a declining FVC, which it was, if you look at some of the graphs, it's very clear what it looks like over 3 years. But you can even make these distinctions about slow decline and rapid decline in the first year, right? Those patients had a 19-fold higher risk of having lung transplant. If they also had a declining FVC, they had a nearly 5-fold higher risk of ILD associated death. The point being, and a lot of the scary data about ILD at this meeting, is that bad things happen to them. You need to identify them early. There's some hope that better treatment of the RA will lead to some better lung outcomes, and that's another story, maybe for tomorrow. But that I like that this data comes from Jeff Sparks' group in Boston, that you could identify the slope of FVC in the first year if you're doing this every 6 months. And that should give you pause and concern. And it really tells me, not being an ILD, aficionado, as many of my young fellows in young rooms are these days. I haven't been so vigilant about getting very early chest X-rays, PFTs, and lung CTs to know where they stand. And I think that if a patient, you have an RA patient and they have the slightest hint of any pulmonary issue, it's incumbent upon you to make sure that they're not going to be, that ILD isn't their biggest problem, and there's a number of other lung diagnoses that go along with RA, but identifying it early could be important in the management. Do you guys see much ILD, and what's your assessment of it and how it impacts your practice, Bella?
I think I agree. Again, I don't screen everybody, but after all this data, I've been like, at the slightest like shortness of breath, cough, something, I start referring them and like getting testing done, because it is pretty scary when they decline like that.
Yeah.
And sometimes, the RA is okay, and like the patients can live with like not that great disease activity. They are not aggressive about it. But like when you see this sort of a thing going on in the lungs, then you can change the management options that you're doing with the patient.
Anthony?
Yeah, I think the group that did less well, the one that you sort of said they accelerated and dropped in the FEV one, probably are the group that must be the rheumatoid factor positive or CCP positive, presumably, or might be smokers. But the large majority of them, even if you took those high risk groups, we're probably not, diagnosing them early enough with ILD. The issue for us is that we're not doing these regular FEV ones, as the study suggests. We're not even doing them every 6 months. But I saw a poster which was yesterday on the use of ultrasound and how lung ultrasound might be less radioactive compared to CT, certainly, but could be done very quickly. And I asked them, they said 10 minutes you could do this. And they had 5 lines that allowed them to not only find ILD, but also bronchiectasis in the rheumatoid patient. So,
Yeah.
I think it's something that we could, consider. I know it's ultrasound is used already in looking at joints, but something to consider if you're not doing regular CTs or lung function on our patients.
Anthony, you mentioned about these patients who are getting worse, rapidly worse, are probably going to be seropositive.
Mm.
I think it was 2 ACRs ago, maybe
Mm.
3. Jeff Sparks had a big analysis of all their patients and shocked me with the data that said that seropositivity wasn't the big predictor I've
Mm.
always said it is.
Yeah.
And when I was taught, it always is that it's the patients, the ones who get really bad RA ILD, have really bad RA, polyarticular disease, erosive disease, extraarticular disease, and strongly seropositive. They found it was a 50-50 split. And so much so that you can't think of seropositivity as the linchpin upon which you're going to be more concerned or do more vigilant. And that's kind of changed some of my thinking and my approach to these patients. And I think it's paid off because the fact is that lung disease in RA leads to worse outcomes, more infections, more deaths, more everything. So it's something that we need to worry about. All
Yeah.
right, let's go. Let's do our second round with Dr. Chen leading the way.
Thanks. So this was actually from yesterday, but I thought it was a new agent that worthy of discussion. This is a sonelokimab. Sonelokimab is a dual IL-17A and IL-17F nanobody, and this was presented by Ian McInnes at the PSA oral abstract session, and these were slightly different from our usual antibodies in the sense that their molecular weight was lighter, is 40 kilodaltons compared to 150 kilodaltons from the conventional antibody. And the idea that because of this, and also it has an albumin binding domain, the idea is that this would bind tightly to the IL-17A and F receptor and therefore result theoretically in higher efficacy. They only presented the 12-week results. The study is a 24-week study. They had 207 patients, and these patients had greater than 3 tender or 3 swollen joints for psoriatic arthritis. And the dosage was 60 milligrams, 120 milligrams with and without induction. They had a placebo arm, and they also had a comparator adalimumab arm, just as a control arm. It wasn't a head-to-head comparison. And they went for the ACR 50 as the primary outcome measure, and they were achieving in the range of 46% in the active treatment arm and 36% in the half-dose 60 milligram arm, and the placebo was 20%. And then the ACR 20 was 72 to 78%. So it did meet its primary and secondary endpoint, but of course it's only 12 weeks. We don't have any structural data, and we don't know what happens in the longer term, but perhaps a kind of new kind of way of delivering some of our cytokine inhibition.
Yeah, so this is in sort of on the coattails of bimekizumab, another dual IL-17A and F inhibitor. And just to remind the audience, the story on that, of course, is that that works incredibly well in cutaneous psoriasis, right? The head-to-head studies on that are, probably, superior to everything else that's out there. And so that's been launched in psoriasis. It has not been launched in psoriatic arthritis yet. They're waiting for the FDA. It probably won't happen until after December of 2024. But it looks good in psoriasis, in psoriatic arthritis, but will it be any better than what's out there? We don't know. And unlike in dermatology where they have head-to-head trials, we don't have head-to-head trials, but it certainly looks okay. Yesterday they had a long-term safety and efficacy report that showed good data for bimekizumab. But this sonelokimab, whatever, is looking like it's following the same path as bimekizumab, with the unusual finding of one thing. And I think this is, and that being from a safety standpoint, the dual inhibitors seem to have a little bit more of candidiasis,
Yeah.
right? Do you remember
Mhm.
the number that they had in their trial?
They had two candidates reported in 207 patients, so quite low, but it's only 12 weeks. So we have to kind of follow
Was
it
that
through to the
disseminated
24.
candidiasis or just
No,
local?
oral
Oral.
candidiasis. Yeah.
And that's the story with the bimekizumab. It's all sort of non-serious, oral mucosal, never systemic. Um, but in the derm world, and looking at both bimekizumab, this one and another one, the percentage of just candidiasis complicating therapy in clinical trials ranges from about like 9 to, I want to say 16, 17%. We don't see that with the other IL-17 inhibitors. So it's much higher, but only in the derm literature. In the rheum patients that get treated with bimekizumab, the numbers are single digit and kind of low. I think it's
Mhm.
like less than 6% or something like that. But thankfully it's not systemic. It's all that mucocutaneous stuff that's easily managed. So it'll be interesting to see how that if the I mean again the issue is if it's mechanistically different, is it going to be is the efficacy or the safety going to be different as well?
Mhm.
And the only safety issue is this candidiasis, which I don't think is a serious one.
Mhm.
And the efficacy clearly shows up in dermatology, may or may not show up in rheumatology. That it's yet to be seen.
I mean, it's
Yeah.
good to have some options if all of
Absolutely,
them work.
Yeah. Yeah.
absolutely. As we said before, too many patients with psoriatic disease, whether skin or joint, are cycling off of their biologics because they just don't seem to last. The question is that because there's so many options for treatment that people are quick to bail out? Or is it because they really do have a higher than expected rate of secondary loss of efficacy? It doesn't seem like they have if anything, their safety profiles on IL-17s, especially look, and pretty much all the drugs in psoriasis look pretty good. The SIE rates and everything else are lower than what we see in RA. But
I
again, I
think
wonder
it's, I mean,
why.
yes, when there's options, you try to sort of get rid of something that's not working
Yep. Well,
faster.
makes the switch easier. That's for certain. Bella, what do you have second for a second option?
So this is a poster 1192 looking at adult onset Still's disease patients, specifically looking at serum CRP and IL-18 levels. And this was interesting because, even though I see a lot of Still's disease patients personally, I was not sending out IL-18 levels for logistical reasons or whatnot. But what I have started doing that. And the results of this study sort of are similar to what I'm seeing in my practice. So it was important to highlight it. They had around 46 Still's disease patients. They were doing serial CRP levels as well as IL-18 levels, and sort of tracked outcomes in Still's as well as flares. And basically, they came up with a threshold for CRP levels of like 10.8, above which there was a sensitivity specificity around 80% of predicting flares or worse outcomes. Whereas IL-18 pretty much tracked very, very well with any flares, as well as development of a MAS. So even those patients who were not in flares and had a higher IL-18 level had higher likelihood of MAS or sort of liver issues. So I think the point to take home from this is that IL-18 is getting more and more available to do. And I think for Still's disease, it's going to be pretty much the standard of care going forward. I think it adds to the current, practice, which is ferritin levels that we do.
So, and I'm not convinced.
You're
I,
not. Okay.
I believe that they're both IL-1. This is an IL predominantly IL-1 inflammasome driven disorder, right? And the mechanism by which IL-1 gets produced is the same mechanism by which IL-18 gets produced. And
Yeah.
by knowing that information, how is it going to make me better? You suggest that maybe it identifies people, one, it tracks better as a biomarker, if you will. and that maybe
Yes.
it identifies MAS. Is there anything else as to another reason as to why I should be doing this?
I mean, we do ferritin for Still's disease patients, right? To track if they are going to get into flares even before they get like a clinically full-fledged flare. So this is how I think IL-18 would also help with doing the same,
See,
but much better.
again, I'm a naysayer on too many things, and I got to look into that. But
Uh-huh.
ferritin is only useful in my mind because it's as an acute, hyperferritinemia is seen in only 50% of patients in stills. And the only reason to
Percent.
identify a
Yes.
rising ferritin or extreme ferritins, extreme hyperferritinemia, is because it is the doom of MAS. It's telling you MAS
Yes.
is here, it's coming, it's going to destroy. It's the only thing that can really hurt a stills patient. And that's why I'll do a ferritin, but I still hang my hat on CRPs and sed rates. But is going to, again, how many cytokines can you order to feel better about what you're doing?
That
We'd like
I
to
mean,
know.
it even helps because there are IL-18 drugs in the pipeline,
Right.
and maybe you would
Mhm.
sort of when you are out of options, I guess, and stills sometimes can get difficult to treat. It will tell you that this is the right patient for that medication.
Yeah. And I'll say what I've said before. I think the best biomarker in Still's disease for activity is aldolase. Aldolase with a normal CPK, but an aldolase that can range from 10 to 50. And not just in stills, but in other IL-1 responsive autoinflammatory syndromes. Follow your aldolase level. You'll be shocked at what it's doing. And they don't have myositis. It's all coming from liver. And I learned this trick from the pediatric rheumatologist at UT Southwestern, who they learned it a long time ago, and it follows other biologic correlates like microarray stuff and whatever. So I like that. Of course, it's a cheap test and maybe a
Mhm.
little bit more accessible than IL-18 levels, which for many of us are going to have to be send outs because they're probably not going to be done locally. So. All right, my last one for today was a session that occurred at the end of today, where these it's called EULAR points to consider, and in this case, this is a document generated by a EULAR task force to look at the management of patients with inflammatory arthritis who also happen to have cancer. So this was presented by Professor Gottenberg, and there's a lot of ways to discuss this, but I want to just basically get into the hardcore stuff of what they said. The bottom line is that patients who are of cancer and that the cancer is treated and in remission, and now you have to manage their arthritis. So that's either they come to you, they develop a cancer and it gets treated. What are you going to do with your therapy? Which therapies do you use? Or they have a history of cancer in remission. What can you safely use? We do know the ACR guidelines, which I think on this are totally crazy and make no sense, other than the one statement which says that a patient who has a solid tumor, that could be pancreas cancer, that could be lung cancer, that could be skin cancer, that can be prostate cancer, breast cancer, colon cancer, that you treat the patient as if they didn't have cancer. The cancer does not go into the equation, not at all. That's the one thing the ACR got right. Their recommendations about lymphoma and hematologic, I don't even want to get into because they're kind of wrong. These EULAR points to consider are getting closer to being right about this because, and I say that because I study this and follow this. They have a task force of 27 people. There were two patients, 25 rheumatologists, a bunch of cancer doctors, and people that were obviously epi related. They did literature reviews. And number one, they say that the point number one is treat treating arthritis in a cancer patient is important for both the arthritis and the cancer. Two, that you have to balance the risks of managing the arthritis with the drugs that you need for the arthritis versus the cancer and its potential pitfalls and/or risk of recurrence. Third is that rheum should be part of a co-management scheme, that the rheumatologist needs to be actively involved and communicating with an oncologist about what should be done. Otherwise, you're letting arthritis management be done by people who know nothing about your disease nor your drugs. And that's a bad situation for the patient. Number four, that a cancer patient in remission who is in need of anti-inflammatory or biologic targeted synthetic therapy, you start without delay. There is no like, let's do something, let's wait, let's get an opinion. You start without delay. Number five was patients who have a history of cancer in remission, that JAK inhibitors and abatacept can be used with caution and only after other alternatives have been exhausted or not available. And the reason that they say that is that there's some early, potentially questionable data, not because there's any indicting data about JAKs or abatacept here. Now we know about JAKs and the oral surveillance study, and that has some concerns. But remember, the cancers that were seen with JAK inhibitors were the cancers that RA patients get: lung cancer, skin cancer, lymphoma. I mean, that's the story. Inflammation gives you those cancers in RA and in PSA and other things. So I don't think it's a JAK inhibitor thing as much as it's an RA and inflammation thing. And that's my opinion on that. But they do say that, again, that you have options here, and maybe you should make JAK and ABA the first. Number six is like the ACR recommendation: a solid tumor. They say ACR says you should treat it as if they didn't have any solid tumor. The EULAR recommendation is going to say solid tumor should get an anti-cytokine biologic or targeted therapy, really a biologic. And the reason is that they're staying away from B cells because they believe B cells may be important in the overall success of cancer management. And I must say that information was a little weakly presented, so we're going to have to wait for the paper. But they are making instead the strong point that I would always make, is that the data is overwhelming about the safety of TNF inhibitors in patients with cancers. It's overwhelming. I mean, we're talking about 20 to 50,000 patients and no negative story. And yet, there people were saying use rituximab where there's no data at all. And it's just because it's approved for what, lymphoma, that it's going to work in all other cancers? I don't think so. Or be safer in all the cancers? I don't think so. But they kind of lump in as anti-cytokine therapy the IL-6 inhibitors. And I don't know the strength of that data, and then we're going to have to see that in the paper. Recommendation number 7, if they do have a history of lymphoma, they say certainly B-cell depleting therapies for treatment of their RA would make sense. And lastly, shared decision-making needs to be done between you and the patient and the oncologist if they're involved. So I like these recommendations much more than I like the ACR recommendations on management that address the safety issue of cancer. But we'll have to see if it changes as it gets published. Usually when it's presented at EULAR like this, it'll be published in the literature, hopefully in the next 2 months. And then we'll be able to look at that and see if it still holds up. At least I think it's going to hold up with what I've seen. How do these recommendations strike you, Bella?
I think the TNF thing, right? I've had patients who come to me and they're like, the cancer is not a problem. Like, I'll deal with it or I'll die with it, but the joints are killing me. And nobody wants to give them the right medication sometimes because everybody's scared. So I think, yes, give them the TNFs when they need it, like right away without being, because initially there was a lot of scare about it.
Yes. Waiting's always a bad idea in pretty much any decision making. Anthony, what do you think of these recommendations?
I agree. I think we should move away from the fear of using TNF. It's certainly in the solid cancers, as you say. When it comes to hematological cancers, lymphoma, we still currently use B-cell rituximab. But is it your what do you do, Jack? Are you happy to have for them to have TNF as well in this the
Absolutely.
hematological ones? Yeah.
Absolutely. Now, if they're getting as a part of they're being actively treated for a non-Hodgkin's lymphoma, for instance, yeah, I'll reserve using combination biologics in that person, but because I do believe that will help them. But there are registries. There's a registry, a Genentech registry of rituximab use in RA patients with cancer, and it's fraught with all kinds of ugly signals as well, because that's what you get when you have a background of cancer treatment. And it looked no better, no safer than what you would get with other therapies. And in my opinion, is that you use, regardless of the situation, regardless of the cancer, you use the best drug available. And there's a lot of experience with TNF, so I'm free. I feel fine using an anti-TNF or an anti-IL-6. I have waited a little bit. I've used some JAK inhibitors in patients with active or past cancer, and only because there's not a lot of data out there. And I've also used rituximab as well. So I think the idea is that it's a little bit to me like pregnancy, meaning the patient needs to be optimally managed for the best possible outcome for that thing, that pregnancy outcome or that cancer outcome. The best possible drug to manage their arthritis is really what you should be hanging your hat on. But I think we need to sort of grow into these recommendations because they are a little bit counter to all the warnings that we've had in the package inserts and FDA hearings and all this kind of stuff. But I still think this is just a forward step on how we can better manage these people. All right, I want to thank my discussants for their review of a pretty active day here at EULAR in Vienna. Tune in tomorrow for our last day, day 4 recap. Same time, same place. I think you'll enjoy that as well. Thank you, Bella. Thank you, Anthony.